Okay, hi. My name's Jamin. I'm one of the BMed Sci students this year, and today I'm going to be talking to you about treatments in psychiatry. Now, I think a lot of you, or maybe about half of you, may not have started your psych rotation yet. So this might be a bit confusing because you kind of need to usually know a bit about conditions before you talk about them. But I think the purpose of this lecture is really just to give you like a whirlwind overview of all the kind of different treatments, and you can through the rest of today, maybe you can just put them in context and apply them now that you have a little bit of basic knowledge. Guess the topics I'll be covering. So firstly, I'll just talk a little bit about 5 neurotransmitters. And then I'll talk a bit about the antidepressants, the mood stabilizers, and then about the antipsychotics. And then very briefly about benzodiazepines, ECT, and then some of the psychotherapies. And at the end, this is probably the most high yield, like if you're exam focused later on in the year, this is probably the part you are most interested in. So this is kind of just a table of different presentations and a correspondence between different patterns and the most likely answer. And it's a very quick table. So that's probably the most high yield part, but the other stuff is probably good to know, even though it may not be as high yield. So we'll start off with neurotransmitters. So the first group of neurotransmitters that I'm going to talk about are the monoamines, and the monoamines consist of 3 neurotransmitters: serotonin, noradrenaline, and dopamine. Now, serotonin is released in the brain by neurons in the raphe nuclei, and the raphe nuclei gets its name because raphe means seam, like a clothing seam in some ancient language, and the midline of the brain kind of looks like a seam, so it's got that little dimple in the middle. And these neurons release serotonin all over the brain. So serotonin is very pervasive in the central nervous system. And the kind of functions of serotonin are they're not that clear, but some of the putative functions are things like memory, appetite, weight control, nausea, vomiting, gastrointestinal motility in the periphery, and also things like circadian rhythm, cognition, thermoregulation. So you can see that serotonin has a lot of diverse effects, and a lot of it's about modulating balance between things. I think just have a very basic idea of what serotonin does, and you can just kind of summarize it as pain, sleep, movement, appetite, and then this kind of nebulous idea of feeling good, because serotonin is thought to be involved in a lot of anxiety and mood pathologies. But the kind of understanding between how serotonin is involved in those pathologies, a lot of it is based around observations of drugs. So it's a little bit backwards to start saying that the serotonin effects can be used to extrapolate information about the drugs, because that's where we get the information from the first place. So the moral of the story is that serotonin does a lot of things in the brain. And it also has a peripheral role in platelet aggregation. So it's got consequences for bleeding that we'll see later. I think I just want to highlight, so you don't have to know the receptors, but I think it's useful to kind of put a framework where to put its different functions. And you already know serotonin from some different areas of medicine. So 5-HT1, or some receptors in that family of receptors, is actually the target of anti-migraine drugs. So you can think that maybe this has some role in either vascular function to do with the vascular pathology of migraine, or maybe to do with pain modulation. And 5-HT3, you'll know from ondansetron, and everyone knows ondansetron. It's the nausea and vomiting drug of choice for chemotherapy. And ondansetron is an antagonist at 5-HT3, and that reduces nausea and vomiting. And we'll see a similar effect in one of the drugs later. So noradrenaline, you'll know noradrenaline from your teaching in the autonomic nervous system. It's all to do with this fight or flight response. And in the brain specifically, it's produced by neurons located in this area called the locus coeruleus. You don't really need to know the area, but I think it's helpful to kind of know where things are located. And just like in the periphery where things are to do with fight or flight, noradrenaline in the brain is all to do with wakefulness and stressful stimuli and responses to attention and that kind of arousal state. So that's kind of the gist. Noradrenaline is still that fight or flight response even in the brain. And just recall back into your pharmacology days where you had alpha and beta adrenoreceptors in the periphery that had a bunch of functions often to do with things like constriction effects and tachycardia, because that's important because not all of the drugs are selective for things that happen in the CNS. So drugs which affect noradrenaline in general will also have effects on the peripheral effects of noradrenaline. Dopamine. So dopamine is the last of the three neurotransmitters which make up the monoamines. And dopamine's quite important for psychiatry because it's got a number of effects. These are usually divided into 4 different pathways, and I don't think you need to know the names of the pathway. What I think is probably more important is to know the basic functions of dopamine in the brain. So you can kind of divide the pathways into a movement pathway, which is the nigrostriatal pathway, which goes from the substantia nigra to the striatum. You've got an attention pathway, which goes from this part called the ventral tegmental area in the midbrain, or the mesencephalon, to the cortex, where it's involved in things like cognition and behavior. You've got this mesolimbic pathway, which is from the same area, but now to another area in the brain, particularly the nucleus accumbens, which is to do with reward, and that's probably the one we think of most often when we think of dopamine. And then you've got this very short tuberoinfundibular pathway, which is just from the hypothalamus, just a little bit down to the pituitary stalk. And that's specifically a pathway to say, don't lactate. So if you know those kind of 4 basic functions of dopamine, you can kind of think about how a dopamine blocker or a dopamine agonist might affect what symptoms you experience. So we know from the nigrostriatal pathway, that's probably the pathway that we're most familiar with because it's the pathway that's affected in Parkinson's disease. And if you have a lack of dopamine activity in that pathway, you get Parkinsonism or Parkinson-like symptoms. The mesocortical and mesolimbic pathways are thought to have a role in schizophrenia. So it's thought that a reduction in dopamine activity in the mesocortical pathway leads to the negative symptoms of schizophrenia, and an increase in dopaminergic activity in the mesolimbic pathway causes the more positive hallucinatory, delusional kind of symptoms in schizophrenia. I think the understanding behind schizophrenia is still very unclear, and whether this dopamine hypothesis is really true or not is still up for debate. But this is the main target for most of the antipsychotics that we'll discuss later. And then this tuberoinfundibular pathway. So that's significant because when you have blockade of dopamine and it's non-selective, you'll end up causing galactorrhea because you've stopped this don't lactate pathway. You don't have to know, I think, that much about the source and the destination. Just kind of know these pathways. I feel like I've seen these words come up in an exam before, so maybe have a vague understanding of what those words are. They're basically just anatomical. So if you know the cortex is to do with cognition and behavior, then you've already got part of, like, half of that word. And the main receptor, which is the target for antipsychotics, is the D2 receptor for dopamine. So acetylcholine, this is not a monoamine, so we've finished the monoamines. Acetylcholine's another neurotransmitter in the brain, and you'll know acetylcholine as the primary neurotransmitter for the parasympathetic nervous system. But inside the brain, it's actually got a slightly more interesting, well, I think it's a more interesting role. And in the brain, acetylcholine is all to do with cognition. So the anticholinergic effects, which you'll be familiar with in the autonomic nervous system, are all to do with things that flow. So if you have cholinergic effects, they make your tears flow, they make your nose flow, they make your mouth flow, they make your gut flow, they make your urine flow. And in the brain, it's more to do with cognition and loss of cholinergic activity in the brain, or neurons which produce acetylcholine, is associated with Alzheimer's disease and cognitive impairment. So there's 2 kind of branches of anticholinergic activity you can think of now. There's that things that flow branch, and then there's this cognition branch. And finally, histamine. So histamine is produced by the hypothalamus in the brain. It's of course got roles in the periphery to do with allergy, and that's one we're very familiar with. But inside the brain, it's more to do with things like sedation and appetite and body weight. I think one way to think of this is if you know about antihistamines, the very first generation of antihistamines were sedating because they crossed the blood-brain barrier. And although they were used for their peripheral effects, the fact that they were sedating was a result of their CNS effects. So that's something you can use to remember, that histamine is to do with sedation. If you get histaminergic effects, if you increase histamine in the CNS, you get sedation. There are kind of some other roles of histamine, but I think that's probably the main one that's relevant for the psychiatric drugs. So we're now going to cover the antidepressants just very briefly. And I think for the antidepressants, because there's a lot of drugs that are used in depression, just kind of have an idea of the drug classes. So I'm going to talk very briefly about some of the specific drugs, but the black cards have most of the information that you probably need. So the first class is SSRIs, and SSRIs are first-line treatment for depression, along with SNRIs, which we'll talk about later, and mirtazapine, which we'll also talk about later. And SSRIs, selective serotonin reuptake inhibitors, they work by, as the name suggests, selectively inhibiting serotonin reuptake. So what that means is that you get an increase in serotonergic activity. And it's thought that this works because one of the ideas around depression is that depression is caused because you have low levels of serotonin, noradrenaline, and dopamine, or low levels of the monoamines. So by increasing the monoamines, hopefully you can treat depression. It doesn't seem like that's actually the case with, I guess, recent ideas around the biological basis of depression, but this is a very easy and simple way to think about it. When you're talking about SSRIs, some cautions you need to take are that, one, you should always, with any antidepressant, check if there is a history of any manic episodes, because antidepressants can precipitate a mixed state or a manic episode, and that's basically where you get symptoms of bipolar disorder, or you get the manic symptoms, the elevated mood, plus depressive symptoms, and that's very hard to treat. You can't use SSRIs if you've used a MAO inhibitor in the last 14 days, and that's because you increase the risk of serotonin toxicity or serotonin syndrome. And you should also be cautioning patients if they're driving or if they're operating heavy machinery, that because the SSRIs can be, they can make you drowsy, they should be aware of that, and they shouldn't do that if they do experience that side effect. And in an OSCE situation, it always seems like the occupation of this inpatient has some sort of relevance to the STEM. It's not like that in real life, but I think keeping an occupational perspective on a lot of these things is also very useful. Now, the side effects of SSRIs, they are very numerous, and unfortunately, it's very hard to remember all of these. I think probably the main ones to remember are serotonin syndrome, which is this kind of triad of autonomic signs, neuromuscular signs, and altered mental status. Essentially, the autonomic signs are you get really sweaty, you get really shivery, and you need to go to the toilet for diarrhea, so things get really active. It's kind of that feeling you get before an exam if it's a really stressful exam. You get neuromuscular signs, and these are things like tremor. They're very neurological-like muscular signs. And sometimes I've seen questions in the past which are talking about serotonin syndrome, but they don't actually mention any of these buzzwords. So they just say things like jerking movements or rhythmic movements. And I think the message is to know what these things are rather than just memorizing these words. And then you get altered mental status. So serotonin SSRIs interact with a lot of medications, and serotonin syndrome is always something you have to have in the back of your mind. These other side effects, so sexual dysfunction is very common with SSRIs, and always something, if it's a counseling station on SSRIs, you need to mention. A lot of these, I feel like you could probably just conjure up some side effects, and they probably are true. Nausea, diarrhea, dry mouth, weight gain, agitation, insomnia. Some of these you can kind of go back to the effects of serotonin in the brain and kind of infer that these would maybe adverse effects, but some of these are harder to know. So just get into the practice of recalling these over and over again, because they are important. And even though these are small dot points, QT prolongation, hyponatremia, and bleeding risk, they're also very important. So fluoxetine is an example of an SSRI, a specific example. And fluoxetine is special because fluoxetine is the SSRI with the longest half-life. And the reason it has such a long half-life is because it produces a metabolite known as norfluoxetine, which persists in the circulation and kind of carries on the legacy of the SSRI. So Because of the fact that fluoxetine has a long half-life, fluoxetine is less prone to withdrawal effects. Usually when you stop any psychiatric drug, you need to be very cautious with tapering it down to make sure that they don't experience withdrawal symptoms. Fluoxetine doesn't seem to be as prone to withdrawal as the other SSRIs, which usually have half-lives in the order of about a day. So fluoxetine is used for a major depressive disorder and a variety of other issues, but mostly for depression is probably the big one for you. Some things to know about fluoxetine: it's contraindicated, or you should be very wary if there's hepatic impairment or there's interaction with cytochrome P450 drugs. And one special thing about fluoxetine as well is that it's the drug of choice if you're going to use a medication in children or adolescents for depression. So if you have to choose an SSRI for a child and adolescent, you choose fluoxetine because it's got the most evidence behind it. The other ones, we just don't know the side effects in the child and adolescent population. So the next class of drugs are SNRIs, which are first line with major depressive disorder, along with the SSRIs, which I just talked about, and mirtazapine, which I'll talk about next. So SNRIs are like SSRIs, except you've just added on noradrenaline. So you've got serotonin and noradrenaline reuptake inhibitors. Oh, I should mention, sorry. So I think it's much more important to know the effects of the drug class than these particular drugs, but I would very highly recommend learning the names of what drugs belong to what class, even if you don't learn anything else about the specific drug. The reason because in most of the EMQ questions, they usually have one drug of each class. And if you kind of put all your money in fluoxetine and suddenly you see fluvoxamine or sertraline come up and you've never heard of that before, then that's very hard to kind of get. But if you know like which class each drug belongs to, then you can kind of get the effects of that drug from the drug class. So they're all pretty similar within the class. And if there's only one drug from each class, then as long as you know the class effects, you can kind of get the answer because all the drugs have different classes, so they have different profiles. So SNRIs, they include things like duloxetine, venlafaxine, and desvenlafaxine. There's another one, milnacipran, but that's not used in the psychiatric setting. It's more used for fibromyalgia. And because these have both serotonergic and noradrenergic effects, you kind of get the same effects of SSRIs, but you just add on this vascular component to it. So SNRIs are more, they have side effects that are to do with blood pressure. So you can get hypertension or you can get orthostatic hypotension. And that's because of the blockade of some of the or some of the upregulation of some of the noradrenergic effects. So you get some of those fight or flight symptoms, palpitations, hypertension. And also you kind of, I think there's an association with this particular version of cardiomyopathy, stress-induced cardiomyopathy, or a Takotsubo cardiomyopathy, which is kind of this zebra, but it kind of sticks if you know it because it's so rare. And that's kind of the main difference between SSRIs and SNRIs. So they're pretty much equivalent in terms of effects. It's just the side effect profile differs. And SNRIs have this vascular component to them. Oh, and I guess some of the side effects that are a little bit different because SNRIs are kind of sympathetic in nature. Instead of diarrhea kind of side effects, you get constipation because that's one of the sympathetic effects. Yeah. So duloxetine, I don't know much to say about duloxetine. It's one of the SNRIs. It's supposedly the one with the fewest side effects to do with the vascular component, but it's also used for major depressive disorder. And it's kind of got these additional effects of urinary retention and liver failure that you should be aware of. Something about SSRIs and SNRIs is that usually they're given in the morning because they can cause insomnia. So you don't want to give that at night because you'll keep people up. The final kind of first line treatment for depression is mirtazapine. And mirtazapine kind of comes under this class of noradrenergic and specific serotonin antidepressants, which is a bit of a long name. But this drug, mirtazapine, and its closely related sister, mianserin, which is not first line, these work in a slightly different mechanism. So they block presynaptic alpha-2 adrenoreceptor. And although it's blocking an adrenoreceptor, because it's presynaptic, it regulates noradrenergic activity. You can think of the presynaptic receptor as like a bit of a feeler for what's going on in the synapse. If there's a lot of noradrenaline in the synapse, then that feeler will detect that there's a lot of noradrenaline and it will produce less noradrenaline. So it's kind of like a negative feedback loop. But because this is blocking that negative feedback, you actually end up with having more noradrenaline, because now that there's a lot of noradrenaline, it can't detect that. So it still produces more and more noradrenaline. And because of that noradrenergic effect, it's also indirectly serotonergic. And that's because the noradrenergic and serotonergic pathways are quite interrelated. But interestingly, although it's serotonergic indirectly, it also blocks a few serotonergic receptors, including 5-HT3, which I mentioned was the target of ondansetron. So as opposed to SSRIs, where you can get nausea and that kind of vomiting side effect profile, mirtazapine is special because you don't get nausea. You actually may even get a reduction in nausea because it's targeting the same receptor as ondansetron. And two other special things about mirtazapine are that it has two very prominent side effects which always come up in the exams in some way or another, and that is mirtazapine causes sedation and it causes an increased appetite or an increase in weight. You know, there's this saying that there's only a few things that are certain in life: death, taxes, and the fact that mirtazapine causes an increase in appetite and sedation. I don't know why, it just comes up in Monash a lot. And I think like the actual prevalence of these side effects is around 50% for sedation and 30% for increased appetite. But in exam land, yeah, it's disproportionately represented. And because of the sedation and increased appetite, mirtazapine is very useful because sometimes these effects are actually desired. So mirtazapine is a little bit unpopular in the younger generation because, of course, I guess the younger generation doesn't want to increase in weight and they don't like to be tired all the time. But in the older generation, or in people who experience insomnia or weight loss as a result of depression, mirtazapine is particularly useful because you're essentially using the adverse effects as useful effects. So if someone's got weight loss and a loss of appetite, or they've got really having difficulties with sleeping, then mirtazapine is the way to go. And unlike the SSRIs and SNRIs, mirtazapine is taken at night because it's sedating. So you've kind of got this contrast between this group of SSRIs and SNRIs and then mirtazapine. And they're all first-line treatments and all equivalent by ECG standards. So they're good to know. The next kind of groups are tricyclic antidepressants. I'm not going to go into this in too much depth, but essentially these include drugs like amitriptyline, clomipramine, dithiopine, doxepin, imipramine, and nortriptyline. And as long as you know the class, don't worry too much about the names, just know what the names are. And these have both the serotonergic and noradrenergic effects, plus anticholinergic, antihistaminergic, and alpha-1 adrenergic effects. And you can kind of rationalize what the additional adverse effects of tricyclics might be based on that information. So if you think about anticholinergic effects, I mentioned that they're all about things, well, the cholinergic system in the peripheral nervous system is all about making things flow. So anticholinergic effects are all about making things not flow. I think in this kind of case, it's really nice to just channel your inner child and do your head, shoulders, knees, and toes. Just go up, like from the top down. So eyes, you get dry eyes because the parasympathetic nervous system normally constricts the pupil. You can get mydriasis if you block it, so the pupil increases in size, and you can also get blurred vision because you've lost that pupillary control. Going to the nose, going to the mouth, you have dry mouth. Going to the gut, you've got loss of gastrointestinal motility, so you've got constipation. And going to the urinary tract, you've got urinary retention. And urinary retention is one of the main side effects of tricyclics. And I think that also comes up a lot. So if you've got someone with prostatic hypertrophy, do not give them tricyclic antidepressants because you'll precipitate urinary retention because of this anticholinergic effect. The other thing to note about TCAs is that if you take an TCA and overdose, it's fatal. So you don't want to give this to people who are at high risk of having an overdose or a suicide. And some of the other side effects are pretty similar to the SSRIs because of those similar serotonergic effects. I think also notes that there are cardiac effects, significant cardiac effects with tricyclic antidepressants. So that's always a consideration in the STEM. If they give you this kind of cardiac picture, you know not to choose TCAs. The next class for antidepressants is monoamine oxidase inhibitors, and this includes the irreversible monoamine, Maury's tranylcypromine and phenelzine, and this reversible and selective drug, which is meclobamide. I don't think these are very popular nowadays. They seem to have been fallen out of favor, but essentially these inhibit the enzyme which breaks down the monoamines. So if you inhibit the enzyme which breaks it down, you increase the levels of monoamines. And as I mentioned before, depression has this monoamine hypothesis where low levels of monoamines is thought to cause depression or be correlated with depression. So by having those monoamines increase, hopefully you resolve some of those symptoms. Monoamine, like the Maury's are very infamous for the cheese reaction, which I think we learned in preclinical years. Essentially, this is when you consume large amounts of tyramine, and tyramine-containing foods tend to be things like cheeses or wines or aged foods, so things like soy or tofu or tempeh or aged meats, cured meats. And when you ingest that tyramine, usually MAO is there to metabolize that tyramine in the GIT. But if you inhibit MAO, suddenly that tyramine is left intact, so you absorb it through the GIT, and that causes a hypertensive crisis because of the vasoconstrictive effects of tyramine. And this also seems quite popular in exam land. So if you get this question where there's someone who's eating cheese or wine or some other aged food, and they suddenly get this hypertensive crisis or headache, Maui is probably the cause. I think, yes, that's probably all for that. So that's the antidepressants. I'm sorry it's quite quick because there's a lot to get through. But now we're moving on to mood stabilizers. And I'm only going to talk about two of them, lithium and sodium valproate. I think the one you need to know the most about is lithium. And that's because lithium is quite involved in terms of the management. So mood stabilizers are used for prophylaxis and the acute management of mania in bipolar disorder. So if you get this elevated mood stabilizers are supposed to try to bring that back into line. The mechanism of action of most of the mood stabilizers is not well known. So I haven't mentioned it here. But essentially, lithium is used in both the acute treatment of mania and the prophylaxis or the maintenance treatment for bipolar disorder. And lithium is very notable because it's got a very involved toxicity profile and a monitoring kind of guideline. And that's because lithium toxicity is very significant and it can be fatal. So lithium toxicity is when you get too high levels of lithium in your serum. And the therapeutic range of lithium in your serum is, I think just remember 0.5 to 1, that's probably good enough, 0.5 to 1 millimoles per liter. And I think you may actually have to know that. And essentially, if you get higher than, say, 1.5 millimoles per liter, you start getting these symptoms of GIT upset, these kind of neurological type movement symptoms like ataxia, hyperreflexia, and clonus, which gradually progress to these neuropsychiatric symptoms like psychosis and seizures and coma, and then gradually death as well. So it's very important to keep lithium in this therapeutic range. And I think there are a lot of questions in the past about what tests you need to do for lithium. So one of them, of course, because you want to keep it in that therapeutic range, is you need to do serum lithium levels. So lithium is not good if someone doesn't like blood tests, because when you start lithium, you need to get serum lithium done quite regularly when you're titrating it up to a stable dose. And the other tests you need to do for lithium are calcium tests, which are to look at parathyroid function, thyroid function tests, which are look at thyroid function, and also kidney function, so UECs. So those are the kind of four main tests you need to do for lithium: lithium levels, parathyroid, thyroid, and kidney function. And there's a kind of timeline for which you need to do these, but I think as long as you're aware of what tests you need to do for lithium, that's probably enough. Some important things to note about lithium is if you're going to measure the concentrations, which you're going to do if you're titrating up the dose, you should measure that concentration 8 to 12 hours after the last dose. And that's important just in real life to know, because clearly you don't want to make the wrong measurement at the wrong time when lithium hasn't kind of been absorbed. And then you make the wrong assumptions about the therapeutic range, and then suddenly you'll give someone lithium when they don't need it, or you'll misinterpret the range, and then something catastrophic could happen. And I think the other thing to note about lithium is that the toxicity of lithium is more likely if you have fluid and electrolyte imbalances. So in cases of acute illness, dehydration, vomiting, diarrhea, which often come up in the EMQs, lithium toxicity is often one of the options, or it was often the answer. Did you have a question? Yeah, that's a good question. I got this from a guideline, and the guideline didn't actually say. So I think you're right. It probably has to do with the thyroid. Yeah, I don't have a good answer for you at the moment, but if you can't find the answer, email me, because 2 minds are better than 1, and I can help you search. So next one is sodium valproate. I'm running out of time, so I'll just very quickly mention that valproate is kind of also this mood stabilizer, and also along with the anti-epileptics like carbamazepine and lamotrigine is used for a bipolar disorder. I guess the important things to know for valproate, I think you might remember this already from preclinical use, but don't use it in pregnancy because it interferes with folate. That's probably the main thing. I think lithium is the main one you need to know. I don't have much to say for this valproate either. So we're going to move on to antipsychotics, and these are used in the treatment of schizophrenia or psychoses. And antipsychotics are usually divided into first-generation antipsychotics, or the typicals, and the second-generation antipsychotics, or the atypicals. The key thing to note about first-generation antipsychotics is that they're most likely to cause extrapyramidal side effects. And the way that these antipsychotics work is that they block dopamine receptors. So if you remember what we talked about with dopamine, if you block dopamine, you'll also unintentionally block some of the nigrostriatal striatal or the movement pathway. So you get those movement type symptoms. And people usually classify extrapyramidal side effects as one of 4 types. So Parkinsonism, which is the very Parkinson-like syndrome, akathisia, which is this kind of restlessness, uncontrollable restlessness, like that restless leg that's kind of, I'm sure everyone knows. Dystonias, which are these kind of like writhing movements of involuntary motor activity. And sometimes they can be quite scary at times, because sometimes, people's heads roll back and their eyes roll back, and then they're just stuck in that position. Or they're in really contorted positions and their neck is really stiff, or they're just not able to open their mouth. So that's got really important consequences if it impacts their functioning or ability to eat. And then there's tardive dyskinesia, which is this kind of lip smacking mouth movements. And last one is very hard to treat. If you see extrapyramidal side effects and you're asked to treat it, you should probably consider changing or reducing the antipsychotic, but the pharmacological agent that is used to treat these is benzodiazepine. And that's just something you need to know. It comes up a lot as well. Other effects of antipsychotics, so they are also very numerous, and I'm afraid you do need to know most of these. So I guess just, kind of get into the habit of recalling these. They lower the seizure threshold, so if someone's got epilepsy, be aware of that. And I might just contrast this with the second generation antipsychotics. So the second generation antipsychotics, or the atypicals, they include mostly things which end in -done or like -pine, like clozapine, quetiapine, olanzapine, and then like paliperidone, risperidone, ziprasidone. And the thing about second generation antipsychotics, as opposed to the first generation antipsychotics, is that the second generation antipsychotics produce less extrapyramidal side effects. But that's not just they're not all good, because it's kind of like a balance. So instead of producing extrapyramidal side effects, the second generation antipsychotics produce metabolic side effects. So they increase your appetite, they make you gain weight, they cause dyslipidemia. So you kind of have to toss up between a first generation antipsychotic where you've got motor side effects, or a second generation where you've got these metabolic side effects. Now for the antipsychotics, you kind of actually do need to know the specifics about each of these drugs in a little bit of detail. So some things that I think will help you. So know that these antipsychotics are generally given by mouth, but some of them come in a injectable form or a depot form, and those ones are asterisks. And the depot form is useful if someone is not compliant, or they forget to take their medication, or if they prefer a depot form of medication. And that's usually given every 3 to 4 weeks, so less frequently than oral medication, which is usually given every day. And some of these antipsychotics have particular associations with them. So haloperidol is known particularly for being the one which has the most extrapyramidal side effects. Chlorpromazine is a little bit special because it's known to cause these photosensitive reactions. So you don't use chlorpromazine in someone who has an occupation outdoors. And then some of these ones, I think at the end with the kind of pattern matching tables, that's probably the part where you'll get the most bang for your buck. But just quickly, aripiprazole is agitation, risperidone and paliperidone, which are both very closely related, one's a metabolite of the other, is related with galactorrhea, so that's the major side effect. And then clozapine and olanzapine are the worst offenders for weight gain and cardiometabolic effects. And clozapine is very special because clozapine is the one that's best at treating schizophrenia, especially the negative symptoms, and has the least incidence of extrapyramidal side effects, but it's also the one which needs the most close monitoring. So clozapine is only used for refractory schizophrenia. And the reason is because it has a really dangerous side effect profile, the major ones being neutropenia, and it can cause agranulocytosis, so you get really susceptible to infections. It can cause myocarditis, and of course metabolic syndrome, reducing the seizure threshold. But I think the main things to note about clozapine is that it's a special one. It's used for refractory schizophrenia. It's very effective, but has really severe side effects, which need a huge monitoring schedule. And I'm afraid you do need to know this. Maybe not rote memorized, but you need to know essentially that there are certain time points where you do an ECG, you do TTE, and you have to do all of this battery of blood tests. So FBE, troponins, CRP, ESR, all of this biochemistry. And that's to kind of get a baseline so you can monitor if these side effects are occurring, and you can titrate clozapine as necessary. The range for clozapine here is very large because you start with 12.5 milligrams and you really titrate very slowly, and you monitor them when you titrate. So you only add like 12.5 in the next day and then 50 milligrams for the next week. And then you gradually increase to something like 200 milligrams, which is like the therapeutic dose. So clozapine is very special in that regard. I'm going to skip benzodiazepines. Actually, I'm going to skip a lot of this because we're running out of time. Key things to note for benzodiazepines. If you get a question about someone going on an airplane, it's oxazepam. Essentially, oxazepam is a really short-acting benzodiazepine. This question comes up a lot for some reason. Or if someone's going in for surgery and they really need something to help with their anxiety. Benzodiazepines that are short-acting are good for a temporary measure to combat one single event that's causing someone great anxiety. For long-acting benzodiazepines, diazepam, that's used for things like alcohol withdrawal or withdrawal from benzodiazepines because it's got a long half-life, so it kind of tapers itself at the end. And that's probably the main things to note. ECT, so ECT is important because you might be asked to explain to a patient what ECT is all about, and ECT gets this really scary rap because, I mean, it is scary because you get put under and then you get electrical current delivered to your brain, and that invokes an involuntary but controlled seizure. Essentially, people get ECT for about 12 treatments, and it's used for severe depression where nothing else seems to work, or if depression is really life-threatening. So if someone's not eating or drinking anymore, and it's shown to be very effective, but it's got these side effects that are very undesirable. So memory loss is probably the main one, and you can think of memory loss because it's quite significant because it sort of implies that there's some loss of your own agency with that. And because you're getting that electrical damage, well, electrical current in your brain, it sort of seems like there might be damage to some structures there. And that seems very scary. And then the other ones to note are muscle aches, which are because of the muscle relaxant that you get given when you get ECT, and then cardiac effects. So very quickly now going on to the psychotherapies. I apologize for how quick this is going. I think what you need to do is, at the end, just go through this review, and this should hopefully get you through EMQs. Just cover the right side and then figure out what the answer is. And these are kind of just review if you want some extra information. But just going briefly through the psychotherapies. So CBT is cognitive behavioral therapy, and it's all about trying to give people corrections to cognitive distortions. And by cognitive distortions, the things like overgeneralizing. So essentially things where your mind just automatically goes to this idea of what reality is. So for example, I think if you thought that everyone around you was trying to, or was judging you because of something about the clothes you wore, or if you're thinking that, oh, everything is going to go really bad or really good, there's no middle way, that's kind of black and white thinking. So there are these cognitive distortions, which are changes in your perception of reality that cause you to feel either hopeless or sad or anxious in some way. And in that respect, CBT is trying to correct those cognitive distortions. So it's good for things like depression or anxiety, where the basis of your feelings of these diseases might be because you're seeing reality in this distorted way. That's essentially it. There's this triad of cognitive triad of CBT, which is about the relationship between yourself, your personal world, and your future. Psychodynamic psychotherapy is this kind of Freudian therapy, which is all about how your relationships in the past with your parents kind of affect your current behavior. And the gist behind psychodynamic psychotherapy is that you have these unconscious internal conflicts that are unresolved, so you're doomed to repeat them. But by I guess having a therapist who you can transfer those feelings onto. So for example, if you've got a father that was very controlling, you transfer those feelings onto the therapist. The therapist can then see them. And that's the transference, or how the patient feels about the therapist. And because the therapist can now see that transference, they can unpack the transference and make those unconscious, doomed to repeat conflicts concrete. So when you make these conflicts concrete, and when people can rationally think about them, you're no longer doomed to repeat them, because you're no longer trapped by this, I guess, this unconscious desire to fix those conflicts of your past. I think psychodynamic psychotherapy is very interesting. There's this really great section in Kaplan and Sadok, which is one of the prescribed textbooks. But essentially, have a read, because it's super interesting. There are some case vignettes that are really nice, which go into this more depth. Supportive therapy. So like the one sentence summary of supportive therapy is that it's for people with a chronic illness who are having difficulty adjusting to the world because of either physical or psychological disability. And it's more just kind of this warm, calming way to help people through and get them some realistic measures to cope. So for example, if someone's dealing with a loss of the ability to walk, that's where supportive therapy would be useful, because you're giving them very pragmatic solutions or ways of coping with that loss. And then finally, DBT is about teaching people skills to, I guess, create a life worth living, and kind of adding to their repertoire of ways of dealing with things that don't go their way. So, and this is specifically for borderline personality disorder. If you just kind of make that link between DBT and borderline personality disorder, you're probably good enough. There are some interesting things about DBT, but no time to go through them. For the exam, I think the most helpful part from this would be just to go through this part. So just cover the right-hand side and quiz yourself on all of these, and then make your own types of these. So in what situation you would use what drug, because a lot of the small details in the earlier slides, like this, like 1 dot point side effects, they tend to come up in EMQs a lot. So side effects are one thing which come up over and over again. So get really good with knowing the side effects of the different medications. And for psychotherapy, as long as you kind of know the indications for the psychotherapy, that's pretty much all they ask in the EMQs. Maybe you'll be asked to counsel someone about what a psychotherapy is in the OSCEs, but at least for EMQs, you just kind of know the scenarios in which you need to apply them. And that's it. Thank you. Oh, and good luck for everything, because you're almost there. You just got a little bit to go, so good luck.